Okay. On behalf of EVST Journal Club, I would like to warmly welcome you all and thank you for joining us today. My name is Slobodan and I will be moderating this session. This journal club is going to be focused on a single paper, which gives us a opportunity to explore the topic in greater depth and to have a more interactive discussion. Before we begin, I would like to briefly outline the structure of the session. We will start with a short introduction of our speaker. Then we will be focused on a presentation by our author, Professor Perini, which will last about 10-15 minutes. After that, we will move on to a moderated discussion where we will address several key questions, and I'm kindly ask both panelists and audience to share their insights and experience regarding these topic. The topic of today's paper is particularly important as it addresses the rare clinical entity, the infection of vascular graft and stent infections in the supra-aortic trunks, a relatively rare but significant condition which affect patients with significant morbidity and mortality. There is no clear consensus about the treatment of these kind of infections, and the occurrence rates is relatively low. There is no clear consensus because there is a fragile balance between radical surgical approaches with more conservative or endovascular options. Overall, this systematic review and meta-analysis gives us a unique opportunity to look at this condition, and I would like to encourage all of the participants to share their thoughts, experience, and to have a great discussion. So I would like to warmly welcome you all in Belgrade this autumn on the 40th ESVS meeting, and that will be all for my part. Professor Perini has kindly accepted participation in this journal club, and I'm kindly asking him to present his paper. Professor Perini, the floor is yours.
Thank you, Slobodan. Okay, so can you see my presentation? Very
Yes.
good. Good evening, everyone. First of all, I really would like to thank Slobodan for the kind invitation, and also the SBS and the VST Journal Club for giving me the opportunity to present our work today. I really believe that this society represents a great opportunity for all of us, not only for sharing knowledge, but also for building collaboration. In fact, this paper itself was developed within the SBS network, which I think highlights the value of this kind of community. So thank you again. I'm happy to present our study. So this was a huge work, just 6 authors, but as you may see, 6 authors from 5 different countries, all within the ESVS society. So Italy, the Netherlands, also New Zealand, Finland, and France. So we started with, as any systematic review meta-analysis, by searching databases. We identified initially 1,303 papers, plus 31 from citation searching. And after the screening and the retrieval and the full text examination, we included finally in the review, so in the qualitative synthesis, 71 papers. Among these, only 11 in the meta-analysis. But let's see more deeply, more in depth, what are these studies that we included. So 71 studies with 236 patients. Among these, we identified 54 studies regarding patches or prosthetic graft infection with a total of 215 patients and 17 studies only about stent infection, so infection in the supra-aortic trunks after an endovascular treatment with 21 patients. A meta-analysis was feasible for 11 studies from the patches and prosthetic graft infection. So 11 studies with at least 5 or more patients for a total of 149 patients, and all of these patients were after a carotid endarterectomy with patch closure. So a meta-analysis for the 17 studies about endovascular treatment was not feasible. First of all, the infection rate of a supra-aortic trunk after open treatment was estimated at 0.7%. This data was extracted from 8 studies with more than 11,000 patients. What is to consider in this infection rate, first of all, is that the infection rate after endarterectomy and patch closure is surely lower than for lower limbs prosthetic bypass infection. It's 4 or 5 times more frequent in the lower limbs. And probably it is even lower after the endovascular treatment of supra-aortic trunk. Probably even lower than the 0.3 reported after EVAR. That may be due to the fact that we use mostly uncovered stent in supra-aortic trunks, and we implant just a small amount of material. So these are the 11 studies included in the meta-analysis. As you may see, these are not really big studies. The largest one is from Fatima 2019 with 29 patients. But by merging all these studies, we managed to perform our estimates on a number of 149 patients overall. The infected materials were mostly dark-chrome patches, then PTFE, but this data should be interpreted as the proportion of use rather than the infection rate for each material type. But what's important about infected material is that we found a 0% infection rate, as at least reported infection rate, if we use a biological patch. So maybe we should consider to use a bovine pericardium if we are performing an angioplasty after a carotid endarterectomy. The mean time elapsed from the initial procedure to the presentation with infection is about 18 months. This estimate had a very high heterogeneity, but this should be interpreted as the fact that infection after a carotid endarterectomy may occur anytime, from the first few days after implantation to more than 10 years later. And this surely underscores the complexity and the unpredictability of these complications. Regarding symptoms or signs after open treatment, symptoms or signs are present always. In practice, there are no asymptomatic patients with a supra-aortic trunk infection. The most frequent symptoms or signs were draining sinuses, abscess, neck mass of any kind, false aneurysm development or patch dehiscence, and bleeding. Less frequently pain, fever, neurological symptoms, but mostly local symptoms or local signs of infection. Preparative imaging, almost everybody underwent a duplex ultrasound examination. This was surely underreported, the 67% of duplex ultrasound usage. CT or even MRI were used mostly for planning. Regarding leukocyte scintigraphy, it was rarely used, and it often provided false negatives. So I would not suggest the use of a leukocyte scintigraphy in case of a supra-aortic trunk infection. PET-CT was never used in the included studies. Maybe it was deemed unnecessary by authors. I really think that an infection of a supra-aortic trunk patch is quite clear, so there is really no need to systematically perform a PET-CT scan. But anyway, if uncertain, I would recommend it. It demonstrated to be a useful diagnostic method in detecting active vascular graft infection with a high diagnostic accuracy at other sites. So if in doubt, perform a PET-CT scan. Regarding microbiology, cultures were usually obtained intraoperatively. Most of these bacteria were Staphylococcus. Staphylococcus epidermidis was more frequently associated with infection that presented after 6 months from the initial prosthetic implantation. But what is really important is that cultures were sterile in about 1/4 of the patients included in the meta-analysis. So cultures were sterile in 25.4% of the patients. Maybe this was due to the fact that patients were started on broad spectrum antibiotic treatment before samples were obtained. So the message here is that we really have to delay antimicrobial treatment until after surgical sampling, of course, if possible, of course. Regarding antibiotic therapy, the reporting was heterogeneous, but the message here is that there is a need for a personalized treatment, and we really need the guidance of an infectious disease specialist for managing these antibiotics, also during follow-up. What is the best surgical management for a supra-aortic trunk infection? I really think that the best surgical management is the management that was most frequently performed in literature. So we should start with a debridement, a complete debridement of the surrounding infected tissues. Then we can move to a complete removal of the vascular material that have to be considered as infected. Then we should move to the reconstruction. A bypass surgery or interposition graft are better than a simple replacement of the infected patch. We should perform the reconstruction by using autologous materials, preferably. Typically, veins were used. Then someone also used autologous arteries, but veins are the most used materials and maybe the best materials. Regarding conservative treatment, a pure conservative treatment is not to be really suggested, but if we consider conservative with antibiotics plus, for example, a relining with a covered stent, that may be a viable alternative in some cases. For example, this is a patient we treated about 10 years ago, a 95-year-old patient with an infection after a carotid endarterectomy, patch dehiscence. Of course, 95 years old, we could not bring him to the operating theater, so we performed a relining with a Viaband stent graft antibiotic, and the result was quite good. The patient is smiling, so this demonstrates a good result of the relining. Vessel sacrifice, both open and endovascular, should be avoided if possible. It led to postoperative strokes. And in case a complete removal of the vascular material is not possible, it is really mandatory to perform adjunctive procedures. So if you cannot remove completely the infected vascular material, perform muscle flaps coverage, wound irrigation, VAC therapy. So adjunctive procedure, if not a complete removal, was obtained. We did this in this woman with a clear abscess in the neck. We couldn't really remove all the carotid patch, but with a complete tissue debridement and a prolonged wound irrigation, the patient did quite well. And regarding covered stents may be really useful if we combine them with vacuum-assisted closure. This is the Endovac technique described by the group of Anders van Eynen and Martin Bjork. It is quite an interesting possibility for supra-aortic tract infection and patch infection, especially in case of bleeding, so in emergency, or in case of complex anatomies. So basically, we perform a relining with a cover stent, usually via band. Then we open the wound and we perform a complete debridement and a complete removal of the infected patch. And then we applied the vacuum-assisted closure therapy. We did this also in Parma a couple of years ago. Of course, we did not know it was called the Endovac technique, but we did it anyway. So this was a patient with a previous carotid endarterectomy, then carotid angioplasty with a very long wall stent with a patch dehiscence and a rupture. As you may see, the wall stent went very, very high up to the skull, so a complete removal was really impossible in this case. There was a draining sinus present, so we performed the relining. We applied the VAC therapy on the neck, and after about 2 weeks of VAC therapy, the wound went really well. The message about surgical management is that all the patients included in all the patients with supra-aortic trunk infection should undergo an antibiotic treatment. That is really, really important and basic for everyone. Regarding the outcomes, postoperative complications were frequent, and in particular, cranial nerve injury were quite frequent, 12.5%, but to note, about 1/3 of these patients had a permanent cranial nerve injury. So if compared to a primary carotid endarterectomy, where cranial nerve injury are not so frequent, and moreover, the cranial nerve injury after carotid endarterectomy are rarely permanent. In this case, about the 30% of the cranial nerve injury were permanent. The mean follow-up was 38 months. What is to note is that the pooled estimate of reinfection was 3.4%. So it's quite low and surely lower if compared to other sites, such as the infection of an endograft, where recurrences or reinfections are surely higher. A couple of words about the set infections after endovascular treatment. So we had 17 studies, and 14 of these studies were single case reports. So we really could not perform a meta-analysis. But what is important here is that symptoms after endovascular treatment are different from symptoms after an open treatment. So after an endovascular treatment, fever is really frequent, systemic sepsis signs are really frequent, and we also had some report of septic embolization with intracerebral abscesses or strokes after an infected carotid stent. Of course, the study has several limitations. First of all, the diagnosis of infection was as reported, and we had to rely as reported by each study's author. We could not perform any comparative meta-analysis, so this was a one-group variable synthesis. All the studies were retrospective with a quite high heterogeneity. So in conclusion, the infection of vascular grafts and endografts in the supra-aortic trunks are rare. They are often, I'd say, always symptomatic, with local signs after open procedure and with systemic signs following stent infections. So what to do? We have to remove the infected prosthetic material, and we have to perform an autologous reconstruction. As an alternative, if not feasible, very important, the drainage and possibly relining with a covered stent, and this should be combined always with an antibiotic therapy. Remember that cranial nerve injuries are common after surgery, and about 1/3 of these are permanent. However, the reinfection rate during follow-up was low. And thank you for your attention.
Thank you, Professor Perini. I would like now to call all the participants to give comment, to ask a question. If not, I have a few. So, uh, again, can you outline the specific challenges in management of infections of supra-aortic trunks, whether they were treated by open surgery or by endovascular techniques?
So surely these infections are challenging, mainly because they occur in a very delicate anatomical region around the carotid arteries and cranial nerves, making surgery really technically demanding. And it's also associated with neurological complication. In addition, this condition is very, very rare, so the evidence base is limited and the management strategies are heterogeneous. Finally, the surgeon really have to balance the risk of an untreated infection, which may be catastrophic, such as ruptures or strokes, against the risks of a complex reoperation. However, our review suggests that when infected material is removed and reconstructed with autologous tissue, whenever possible, of course, outcomes are generally good, reinfection rates are low. So finally, in general, I really suggest to operate on these patients.
Yes, thank you. Also, you in your paper, there is a estimated infection rate approximately of 0.7% for patients that were treated with carotid patch. Um, what do you think about that? Is it clinically meaningful or is it significant? And do you think that the eversion technique in that manner would be a technique with more, which is more secure for patients?
So the estimated infection rate of 0.7 with endarterectomy with patch closure should be, of course, interpreted carefully, but I do think it's clinically meaningful. It confirms that these infections are very rare complications after carotid endarterectomy, and furthermore, consider that this rate may actually be overestimated, so it may be even lower because our review focused on studies reporting infection, and this, of course, introduces a publication bias. So the estimate should be interpreted as an approximate magnitude rather than a precise risk. And it also highlights the importance of preventive strategies such as perioperative antibiotics and maybe patient selection. Regarding the eversion carotid endarterectomy, personally, I prefer that technique, so I usually perform eversion endarterectomy. And if the few cases I do not perform eversion, I use a bovine pericardium patch. Sure, eversion carotid endarterectomy is a little bit more difficult than patch angioplasty, I think. But once you used to it, it's really more simple. It's really simple. It's faster, and theoretically, you may reduce the risk of postoperative prosthetic infection.
Yes, of course. I totally agree with you. I come from an institution where we perform around 800 carotid endarterectomies per year, and all of them are performed by reversion technique. And we have a relatively lower percentage of infections. So that's why I'm asking that. Do we have any question from the audience, please?
Uh, I would I would like to ask a
Yes, Ilke.
well, yeah. Thank you very much, Professor, for the presentation. It was really, really amazing to see it. I have just two technical questions regarding the endovac. So, do you put the, let's say, the vacuum sponge directly on the artery, or do you prefer to first like close the platysma or some facial layer and then to put it? And the second question is, what kind of how much pressure do you put on the vac? Because when we put on the lower limbs, I think we can use higher pressure. And on the neck, do you put similar pressure or lower? Thank you very much.
Okay, thank you for your question. So, This technique was described as the sponge applied directly to the carotid. When I performed it, it was just one case. I preferred to perform prior a muscle flap with the sternocleidomastoid and then apply the VAC therapy. But I really think I've seen the results by Anders. They are quite good, so I think you can apply it really directly to the carotid vessel. And regarding the vacuum pressure, let's say, I think you can start at 120 and lower it if the patient has any discomfort. Of course, you should also consider if there was any residual bleeding after your operation. So if the hemostasis was not perfect, maybe you should start at a lower pressure for aspiration. You may start at 60 or 70 and then go up. But you should really tailor also this technique for each of your patients.
A follow-up question on that. Can you define a group of patients on which would you perform Endovascular technique instead of open surgical reconstruction?
Yeah, the first choice is always an open reconstruction with autologous reconstruction. But there are some cases where the risk would be too high. So, for example, in case of bleeding, and maybe you cannot really manage to clamp the carotid artery safely. So in case of bleeding, I would perform the VAC therapy. Or in case of really complex anatomies, or where you really think you will not really be able to explant the whole vascular or endovascular prosthetic graft. If you, after carotid endarterectomy, sometimes the stent is really, lands really distally in the internal carotid artery, and complete removal would be really, really complicated, if not impossible, as the case I showed you. So in these selected patients, I would go, frankly, for an Endovac technique. So in case of bleeding and in case of very complex anatomy or impossibility to explant the entire prosthetic material.
Yes, thank you. Any other questions?
Yes, thank you very much, Professor, for the wonderful presentation. I was wondering, should we, because there's a very wide range in the infection, in noticing the infection, should we consider them as low-grade surgical site infection? Is it an infection from somewhere else in the body, more bacterial infection? What are your thoughts on that?
Yeah, sure. Thank you for your question. Sure, there is a difference between supra-aortic tract infection and the infection at other sites. So the causative agents are a little bit different. For example, Staphylococcus aureus was more associated with early aggressive infection. The Staphylococcus epidermidis was often seen in later infection. Also consider the relatively high rate of negative culture, so that may be infections that were there for a prolonged time, maybe after antibiotics. Of course, other causative agents that are quite frequent elsewhere are nearly absent in the supra-aortic trunk. I'm talking about Candida, I'm talking about, for example, Escherichia coli. Maybe most infections in the supra-aortic trunks originate from skin contamination during surgery. Maybe that is of course, maybe that is the cause for infection in supra-aortic trunks. Gram-negative organisms such as the E. coli are more typical of abdominal graft infection, for example, due to the proximity to the gastrointestinal tract, or the same for Candida or other fungal infection beyond immunocompromised or critically ill patients. These mechanisms are much less common in the supra-aortic trunks. So yes, maybe prevention is the key, even though, I mean, we're talking about less than 0.7% infection rate.
Yes.
Maybe the prevention was, as Slobodan earlier said, the inversion carotid endarterectomy.
Yeah, but the learning curve is pretty long for erosion technique. Okay, anyone else? If not, I could ask about the antibiotics. What was your conclusions from your paper? Uh, do we need to administer empirical antibiotics before the diagnosis, or should we wait for the specific agent and specific antibiotic?
Yeah, it's really better to wait for the specific causative agent. So after an endovascular treatment, maybe you will have a positive blood culture that really helps in guiding your antibiotic treatment. But in open surgery, after open surgery, blood cultures were generally negative. So if possible, and it is quite often possible, I think, after an infection of a patch in the supra-aortic trunks, because you rarely have bleeding, you rarely have septic signs. So I think you can wait a couple of days, operate the patient, and take specimens or intraoperative samples, and then start antibiotics at the moment. Of course, you start with empirical antibiotics at the moment of your operation, but then you can move as soon as possible with targeted antibiotic therapy, targeted and with a clear, I hope, infective agents. Maybe this would not be true for very, very late infections, but if possible, wait 1 or 2 days doesn't
Yes.
really change anything, and you may find the real causative agent.
What about the duration of antibiotic treatment after the surgery and after?
So that was really heterogeneous. It's at least 6 weeks. Sometimes it has been prolonged, someone also for 1 year, and I'm talking about after at least a complete debridement of the surrounding infected tissues. So 6 weeks is really, I think, the minimum, but the real message is that you have to ask the help for an infectious disease specialist, because he really can manage antibiotics better than you can, and he can also follow the patient over time.
Yes. 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 Okay. Do we have any question? Other in the audience? Nadia, Elkin? No. Okay. So Nadia, what do you think? Should we conclude with this?
Yes, I think so. Thank you very much for this wonderful presentation. It was a very nice overview, and thank you for walking us through our questions and answering them. So I'm very pleased.
Thank you,
Thank you
Professor.
very much for your kind invitation. It was really a pleasure for me, and I hope to see you soon. So I think I'll see you in Belgrade, Slobodan,
Yes, of
in
course.
this October.
Yes. Yes. So thank you very much, everyone, and see you soon in the April and the next